Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hello everyone, welcome back to Cardiovascular Matters. Got an interesting topic this week. Dr. Walker and I were talking about people that you know that appear to be perfectly healthy and basically died of a cardiac event, and then their family members are left thinking, well, what on earth, what can I do? What should I have looked at? So today's podcast, we're going to discuss that. What should the person that has a family member that has had some type of cardiac event and they're wondering what should I be looking for? So Dr. Walker, I'm going to have you take this over and basically enlighten the patients on the test and the diagnosis that you would go through with a patient like that walks through your door, asymptomatic, but worried well.
Sure, Terry, that scenario is one that I encounter daily with patients. Someone has been close to someone who died, and they said, gee whiz, this person was active, they could run, they could do these things, and suddenly died. That happened to be a cardiac event. And cardiac events are, of course, the most common cause of death. It's cardiovascular reasons are the number one cause of death by far, followed by cancer. But clearly, easily number one are cardiovascular events. And typically people do have some warning symptoms. Often we don't recognize those warning symptoms because they may be subtle, but there are people who have no warning events at all.
Right.
And it's an important thing to make the diagnosis. Now, I make the analogy here to a car. Car engines can fail, and a lot of things can make them fail, but we know certain things can help us limit that failure, and that is routinely changing the oil, checking things out. And we do that. We look at every certain number of miles, we change out oil, we change out tires. We do that, and we should ask ourselves sometimes, when is it appropriate to do some checkup, and what is an appropriate checkup? Mm-hmm. So let's look at what are the clearly known risk factors for cardiovascular disease and for cancer for that matter as well. And what might an appropriate checkup be? So all of us have seen with cancer, the colon cancer screens and the x-ray screens for lung cancer, mammograms. There's a lot of that. But by and large, people don't think of screening for cardiovascular disease, even though it kills a lot more people. So there are risk factors that we know really increase the risk of one developing cardiovascular disease. They include the following: a family history of cardiovascular disease. Now, my father was a farmer, and he used to always say, if you plant butter beans, you don't get roses. And there's a lot of truth to that. And our genetics often determine not just how tall we are, or our hair color, or our eye color, but they determine how our body deals with foods and other things. And those genetics may predispose us to having heart disease. Right. So family history is very important. Mm-hmm. High blood pressure, very important. High blood pressure is common. Mm-hmm. And, I've got to tell you, there are many people who can have 100 very high blood pressure readings in a doctor's office, and they'll say, well, doc, this is just, they blow it off because people you don't feel high blood pressure typically unless it's crazy high.
Yeah.
And they say it's white coat syndrome. Mm-hmm. I don't really have high blood pressure. However, then you may do a test called an echocardiogram, where you're using ultrasound to look at the heart, and that heart muscle is really thick. Mm-hmm. Well, the heart muscle doesn't get thick unless that blood pressure has been up, or unless the left ventricle has faced strain. And usually the most common cause for that is blood pressure. And cannot tell you how many people I see that say, all I have is white coat syndrome. And some of my former professors, in Boston used to say very commonly, white coat syndrome is one of the greatest hindrances to really treating people who have Gordon variety high blood pressure, although there are some people that it truly is white coat syndrome, and those are hard to differentiate. There are some who just get so nervous and raise their blood pressure, but typically that can be determined real quickly. If the heart's thick, it's not just white coat syndrome. It's not episodic blood pressure. It's high blood pressure most of the time. The next risk is abnormal lipid metabolism. We call that hyperlipidemia. Often we call it high cholesterol. Those are the things we use. Now, going all the way back to around the time of the American Civil War, a very famous Austrian pathologist named Virchow suggested that abnormalities in the detergents that carry around our fats in the body, that abnormality in those could result in deposition of these fats in our blood vessels, resulting in atherosclerosis. So what happens initially, there's a little injury, some of this gets into the blood vessels. Ultimately, it starts to choke off the blood vessel. If the plaque is the buildup of this material, if it ruptures and we get a clot, that's often when a heart attack occurs. And so again, abnormal lipids may do this. Now, sometimes there are signs of abnormal lipids. People may have little white spots on the inner part of their eyes or on the tendons of their hands, but that's the unusual patient. Most people, it just requires a blood test looking for this, and we can see these abnormal values. Next would be diabetes. And both overt diabetes where blood sugar is really, really high, or what we call chemical diabetes, the patient whose blood sugar is mildly high, they eat the wrong things, it goes up. But both of those are associated with an increased risk of heart attack and of other problems. Cigarette smoking. Cigarette smoking, and really smoke inhalation of any sort, but cigarette smoking is the one that we've studied the most. Cigarette smoking is an independent risk factor. Cigarette smoking makes our arteries spasm, and it makes you more likely to form clot. And cigarettes affect certain blood vessels more than others. For instance, I do a lot of work in saving legs as well as heart. And when we develop blockages in the arteries in our abdomen or in the upper leg, almost always those patients are cigarette smokers. And those that develop blockages down below the knee, almost all of those are diabetics. Now, are there exceptions to that rule? Yes, but that rule typically holds. Now, cigarette smoke is very interesting because the earlier we're exposed to it, the greater the risk. For instance, if all you were going to smoke was, I'll just pick an arbitrary number, 1,000 cigarettes in your life, that 1,000 cigarettes, if you took them as a child, would carry far greater risk to you than if you did it all late in your life. So early exposure increases the risk of both cancer and of developing heart disease. There's some other parameters that we often don't think of. Things like inflammation within the bloodstream. And we've talked about an inflammatory marker called C-reactive protein, which is a measure of inflammation in blood vessels in particular, and is associated with higher rates of heart disease. We now know that patients with heart disease who have high C-reactive proteins benefit tremendously from adding the drug colchicine, which was historically used just to treat problems like gout. When you got gout, you would take a whole lot of colchicine until actually you would get a little bit nauseated, sometimes very nauseated, and then the gouty pain would go away. That's very high doses of colchicine. But with these high inflammatory markers, low-dose colchicine taken every day, which is associated with almost no symptoms, can lower that C-reactive protein and lower risk. In fact, it can lower risk as much in those patients as high-dose statins or some of these other drugs which really lower cholesterol. So if we have any of those risk factors, or certainly if we just simply get to an age of 55 or greater, it's probably reasonable to be checked. And what would you check? Well, first off, a blood pressure measurement. a general physical exam, listening to the lungs, listening to the heart to make sure there are no murmurs. Pulses should be checked in the feet. We would look for swelling of the legs, varicose veins, other things such as that. But a general physical exam often clues us into some disease. Basic blood profile, blood drawn from a vein, looking at blood count, looking at things such as your cholesterol and the other lipoproteins, looking at kidney function, looking at blood sugar, looking at liver tests. A general screen like that can often give us a clue that a person may be headed for some problem. If a person is asymptomatic and those tests are all normal, but let's say they have smoked a lot, let's say that they may have had diabetes, and we know that people with diabetes, even if they develop blockages, often do not feel chest pain, or they may have had high blood pressure. There are other tests that can be very helpful. In the high blood pressure patient, in particular, a patient who has a heart murmur, checking an echocardiogram, an ultrasound test that's basically painless and riskless, can let us see the structure and function of the heart. We can measure the sizes of the chambers and determine if there's any significant risk. So that's one test. A treadmill test may be a helpful test. And a treadmill test allows us to put a patient through a form of exercise so that even though the heart at rest may be getting adequate blood supply, perhaps it is not adequate when we stress the heart a bit more. And we may see an EKG change, or we may develop arrhythmias. Now, in some people, they can't exercise, or there may be some people who just looking at the EKG with exercise may result in what we call false positives or false negatives, where we may pick up or miss disease. Then we can use some of the nuclear tests that exist. Those would be PET scans or Lexi scans. And I think PET is clearly the best of those. It has the best diagnostic predictive accuracy. It results in less radiation exposure, but there is some radiation exposure with it. Now, one of the other tests is just to do a very low risk, very painless exam called a calcium score. With a calcium score, one just lays in a CT machine for about 1 minute. The CT machine very quickly takes an image and tells us, is there calcium in one's coronary arteries? If there's no calcium, that person is very unlikely to have atherosclerotic disease within the heart. If, on the other hand, that level is high, there is a greater risk of that. Very, very high levels, much greater risk. But it does not necessarily mean the heart's starving for blood, because sometimes we can have a very high calcium score and the test, we can do other tests, and the heart's not starving for blood. In that patient, though, if you're seeing that high calcium, it means there's atherosclerosis going on. And it would make you more likely to want to really lower that patient's cholesterol, make sure that they're not smoking, make sure that that the blood pressure is controlled and the diabetes is controlled, to lessen their risk down the road of going on to have a heart attack or a stroke. Then that same exam, certainly the physical exam should listen over the neck. The carotid arteries are here in the neck, and they run up, and we would listen to those. We should hear nothing when we listen over that part of the neck. If we hear a whoosh sound, that's called a bruit.
Right.
And that can be indicative of blockages in the arteries to the neck, which may be a clue that one is at risk of stroke. We check the pulses in the legs. We check the pulses in the upper leg, behind the knee, in the feet. And those pulses, if present, mean blood is getting to that area fairly well. And if absent, means that we probably have some blockage there that, we don't necessarily need to open that blockage. The leg may not be in any jeopardy, but it gives us an idea of risk and what we should do for a patient. So just like it is not good with your car, and that's why I started with that. If in dealing with our cars, we waited for the car to start knocking before we checked the oil,
Right.
the problem would be that we would have a very damaged engine by that point. If we waited for the tires to blow out before we change them, for problems, and we'd have a major problem. The same is true with the body. I think preventive maintenance can be very important. I have long argued that one of the problems in American medicine is we're getting to people too late. We're getting to people after they've had heart attacks, after they've had strokes, after they've developed gangrene of a toe, after they have a venous ulcer. If we certainly could approach those problems earlier, then the recovery is much more likely. The likelihood of extending that person's effective life is much greater. And I think we could do a better job with certain screening. And I have hopes that with some of the new direction in healthcare, that will be coming out of our government, that perhaps some of these screening issues are going to be looked at, because many societies have shown these to be very cost effective and to improve healthcare in those areas.
That's such great advice. Obviously, if you can catch something before it becomes a big problem, you can correct it. And what a great discussion on if you're a patient. Again, I like to call that the worried well, where you've seen a family member or someone, even a close friend that appeared to be perfectly healthy, have a major cardiac event that could lead up to even death. What would you do? I mean, if you want to get checked out, and it sounds like just going in and having them listen to your vital signs, take some blood, look at the chemistry within your blood. Those are all very easy, quick, very painless ways to find out if there's an issue. And if it does lead to issues, then there's a few other tests that can be done that can really isolate what's wrong, and certainly go in and there's certainly treatments for all of that. So once again, I think this is very helpful for patients out there. And if you are the worried well, again, you can get a hold of Dr. Walker's group at www.cardio.com. Be sure and like and follow us on the podcast here, and we'll continue to discuss these important issues. Dr. Walker, once again, thank you so much. And we'll be back in a week or two with more information.
Thank you, Terry.
Thank you.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.